And these were published in the Best Practice Guidelines, published in 2014, just earlier on this year. And these are very simple. We want infants and children to grow normally. There are no such thing as CF-specific growth charts, and that's because we should expect our children with cystic fibrosis to grow the same. Older children and adolescents, we want them to have a BMI around the 50th centile. This is our goal. And in adults, we want the nutritional status to be good, as a BMI of 22 or 23. Now these are our goals for all of our patients, whether you work here or whether you work somewhere else in Europe or worldwide, regardless of the age, regardless of the sex, regardless of the genotype, regardless of the environment. These are the aims which are fundamental for all of our patients. This is what we should be aiming for. So I want to explain a little bit why these are our goals and how we can achieve them. Now we want our infants to grow normally, but what is normal growth? So we have WHO growth charts that I no doubt you use and we use, and are used widely throughout Europe and through America. Growth charts like these describe how children should grow. And what we look for on these charts to show normal growth is two things. The first is trend. So we're looking that a child follows the same centile over time. So you can see in this example here, we've got this child following the same line over time. That's the first thing. The second point is that the child is proportional. So we want the child's weight to be on the same line as the child's length and as the child's head circumference. So they should be the perfect package. So proportional growth with a steady trend, this is normal growth. This is what we should aim for. Now as the child gets older, we use BMI to assess normality. And whether you're a child or an adult, we calculate BMI in the same way. So in children, when we've calculated the BMI, it's plotted on a growth chart, which is specific to BMI. And we aim for the 50th centile. So the BMI of a child changes as they get older. So we require to plot them on the charts. If you're an adult, your BMI numbers always stay the same. The range we're looking for stays the same. But what's the link between BMI and CF? Well, this data was published from the American colleagues. Several thousand children went into this data. And this looks at BMI centile compared to lung function. And it's very clear. The better your BMI, closest to the 50th centile, the better your FEV1. The better your nutrition, the better your lung function. And looked at the opposite way around, the worse your BMI gets, the worse your FEV1 gets. And this is irrespective of age or sex of child. And this link between BMI and lung function is seen in adults as well. Again, the better the BMI, the better the lung function. As BMI falls, so FEV1 falls. Now it's a little unclear which comes first. It's like the chicken or the egg. Possibly BMI improves because lung function improves. Possibly lung function improves because BMI improves. Regardless of which one is right, the emphasis is the same, that BMI and nutritional status and lung function are very interlinked. So we show that better nutritional status can lead to better lung function. I need to make a point at this stage that BMI does have limitations. So if we look at this child as an example, this child is following the same centile over time. They are in proportion, they're following the same height centile. If we look at their BMI and plot their BMI, the BMI plots on the 50th centile. So we may look at this and say, well, this child is doing perfect. But actually, there's more to it than that, because children have a genetic potential for growth. But we need to ensure that we're achieving this. And the best way to do that is to look at adult height. So we can use an adult height comparer, and we mark on here the parents' heights, the father's height and the mother's height. We then draw a line between the two, and then 2 centiles up and 2 centiles down. This represents the expected height potential of a child. So we can predict how tall a child will be based on the parent's height. So for this child, with parents that are this height, anything above the 9th centile for height is meeting their genetic potential. So this child that I showed you earlier on, they look like they're doing well, and their BMI is good, but their height is below the 9th centile. So they're not quite achieving their potential. So they may look good, but there's more to it. So a large amount of data over the last 15 years has linked early nutrition to long-term implications. And this data published from last year this data was from America, and it's several thousand children, 3,000 children were followed up. And what we see from this data is when we looked at their BMI at age 4, they took the BMI at age 4, this was if your BMI was on the 50th centile, and it saw a natural decline in lung function over time. And this is normal, this is what's to be expected. However, if your BMI at age 4 was less than this centile, less than the 50th centile, the fall in lung function was more dramatic, and the end result was a poor lung function at age 20. So the nutritional status we achieve in early life can have long-lasting effects. This data really showed that the greater the weight at age 4, the greater the height of the child, the better their lung function, the fewer complications they had, and the better survival they had. And nutrition, even at age 4, can have these long-lasting impacts. And in practical terms, we're talking about a weight for age. If the child is the average weight for their age at age 4, this will mean fewer exacerbations, fewer days in hospital, and lower rates of CFRD. And there's been other such data that's linked early nutrition and long-term benefits. So we know that if children achieve their birth centile, the child is born on the 25th centile. If they're able to achieve and catch up to the 25th centile before the age of 2, it predicts better lung function at age 6. So better nutrition early has long-standing benefits. One of the best ways to describe this is looking at newborn screening versus diagnosis by symptoms. So this study from the Wisconsin group in 2001 took 2 groups of children with cystic fibrosis. All of them were diagnosed by newborn screening, but half of them were randomized to only get the diagnosis if they presented with symptoms. And what they did was they looked at these group of children and compared them, essentially comparing early diagnosis with late diagnosis. Now what they found, you see here shown in the red, this is the screened group, and this is the group that were diagnosed late by symptoms. And this scale here measures the incidence, the prevalence of having a low weight. And what it showed was if you had newborn screening, if you were diagnosed early, the chance of being underweight at age 1 was about 10%. But if you were diagnosed late, the chance of having a low weight for your age was a lot higher, it was about 50%. So early diagnosis can have a dramatic impact to the nutritional status at 1 year. And not just at 1 year, because actually this data went on to show that those children that were diagnosed earlier had a lower prevalence of low weight up until the age of 13. And those children that were diagnosed late, they went on to have a more likelihood of poor nutrition up to the age of 13. And the same was shown with height as well. So early diagnosis actually allows for better nutrition later. Now another study that was very interesting showed how you can improve lung function even in a relatively short space of time by improving nutrition. Now in this study they took children at age 3 and children at age 6. Now these first letters, circled here, represents the nutritional status at age 3. And A stands for above the 10th centile, and B stands for below the 10th centile. So what we see, the letter to the left is at age 3, and the letter to the right is age 6. So what they showed was that this group here, these children had good nutritional status at age 3, and continued to have good nutritional status at age 6. And their lung function was the best. This group of children had good nutritional status at age 3, but it got worse, and their lung function dropped. This group represented those with poorest nutrition at age 3, and still had bad nutrition at age 6. They have the worst lung function. But the most important point of this study is that this group here, who had poor nutrition at age 3 and better nutrition at age 6, actually had improved lung function. So you can improve lung function by improving nutritional status, even within the first several years. So good nutrition early leads to good lung function later, and improving nutritional status can improve your lung function. And the last study I wanted to highlight to you is about body image for children with cystic fibrosis. This is adolescents. And in this study what they found was as you improve nutritional status, so you improve their image in terms of their BMI and their image in terms of height. So if you improve children with cystic fibrosis' nutrition, you improve their quality of life. And this is very important. So one of the things that I do is I work a lot with the families of these children, and I asked a group of parents on Friday, we had a clinic on Friday, and I asked a group of parents what their goals were. Because our goals, my goals, are based on lung function numbers, BMI numbers, and weight numbers. So I asked some parents what their goals were. So I'll show you the video of what they said.
Live to live a very happy and fulfilled life, wanting to get proper care, spend less time in hospitals, to be able to treat him at home, and to be able to receive all the support that he needs.
My goals for Finton would be that he leads as normal a life as possible, doesn't feel restricted by having cystic fibrosis, and that we keep him really well as possible, so he spends as little time away from home, school, and hospital.
Fits in with his friends really, he doesn't look any different or feel any different.
Well, obviously I want him to be healthy, to be well, to be normal really, the same as his brother, not to be treated any different to any other child, and to lead a normal life.
So you see, the parents' goals, they're the same as ours, but they're not described the same. So we look for lung function numbers, weight numbers. We want children to be taller so they've got better lung capacity. We want them to improve their BMI so their lung function is better in 3 years' time. And the parents want this too, but really parents want the very simple things. They want their child to be normal, and nutrition can help that. They want their child to fit in with other people, and that's our nutritional aim, for them to be normal. And they want children to spend less time in hospital, and nutrition can improve that and prevent more frequent infections. So how can we do that? How can we meet the nutritional goals that we've got? How can we meet our goals? How can we meet the goals of our patients? On a very basic level, we know we need to give a high-calorie diet. And the high-calorie diet is based on providing an excess of calories to meet the demands. And this is estimated to be between 120 to 150% of our diet. I'll give you an example. This is a child here at age 10. The normal calorie requirements of a child age 10 are around 2,000 calories a day. A child with cystic fibrosis will require 120% of that, which is around 2,500 calories a day. And we need to be achieving this calorie intake. And the reason for that is that we have a constant battle. We need to provide sufficient calories because we're fighting malabsorption and we're fighting an increased energy expenditure. So it's very important that we provide sufficient calories to make sure we gain weight. And we provide a high-calorie diet in a simple way by giving a high-fat diet. And this approach has been around for 30, 40 years. And this approach began with the Toronto group, who showed that when they give their patients high-fat, high-enzyme treatment, they had better survival than the group from Boston, who gave their patients low-fat diet and not enough enzymes. So from this time, the focus is on providing sufficient calories through fat. And we know that the cystic fibrosis patient requires about 40% of their calories to come from fat. And that's compared to a child without cystic fibrosis that gets about 30. So what does that mean in practice? Well, if we take our child as an example, their calorie requirements were 2,500 calories a day. 40% of those calories should come from fat, which is nearly 100 grams of fat a day. Using this principle, children with cystic fibrosis can achieve the right calories and achieve weight gain. But we have to show our families how to do this because it's not as simple as it looks. We have to show our families that a child with cystic fibrosis still requires good quality foods, but the focus must be on high-fat foods, foods that provide lots of energy in a small quantity. And the best thing about my job is being able to see that small things make a big difference. And I see this in the children that I care for. So I'll give you an example. If a child was to drink skimmed milk, and they drank 500 mils of milk a day, that would provide them 185 calories, and this is over the course of a week, is around 1,200 calories. Now if you choose a milk with a little bit more fat in it, the calories per week go up. And if you choose a full fat milk, this one here, see the calorie requirements, the calorie intake goes up even more. This is a small change. It's picking the right milk, that's all. But when you multiply out the difference over the course of a whole year, the difference between giving a low-fat milk and a high-fat milk is 49,000 calories in the course of a year. It's a small difference, a small change, but it has a big impact. And those extra 49,000 calories will improve nutritional status. So we want to focus on high-calorie foods. Most of us don't need education on what foods are high-calorie. They're the foods that we generally avoid. We want to focus on good quality, high-fat dairy products like milk and cheese and yogurts, but also focusing on good quality fats like nuts and seeds, and all these foods that contain high amounts of energy in low amounts of weight. So we need to give our children a high-calorie diet to meet their requirement. We also need to fortify their diet. And again, this is another example where small changes have a big impact. So for example, if you take a child and they have a portion of rice, and they have a portion of rice twice a week. Over the course of a year, that equates to 13,000 calories. If you mix in 5 grams of butter with that rice, over the course of the year, that's an extra 5,000 calories. So if you mix in 20 grams of butter, which is easy to mix into 100 grams of rice, it melts, the calories per year significantly go up. These are small changes. I'm telling you, they have a big impact. They shouldn't be underestimated how much they can improve the situation. So we want to give high-calorie foods. We should fortify a child's diet by adding extra fat, butter, oil, cream. And we need to be ensuring they're having regular meals and snacks, making sure that children are not going too long between eating. And there are different time frames when this advice is more important. This advice is, again, applicable to all patients, no matter their age, genotype, sex, and environment. But there are times when they become more important. So a colleague of mine, Willie Woolston from the Netherlands, was able to show this is our target, 120% of requirement. And she looked at different children's ages and how good they were at achieving this marker. And what she found was that children under the age of 9 generally stay above the line. They're doing well. But as children get older and they go into adolescence, they're less likely to meet these requirements that we need them to do to ensure good nutrition. And it's the same, girls and boys are the same. And this has been shown in other work by Helen White, one of my colleagues from Leeds, who showed that compared to non-CF children, BMI is generally poorer in youngest children. It's much the same as children without cystic fibrosis at this age group. But by adolescence, nutritional status in the CF group is normally poor. So we need to pay particular attention to the nutrition of our adolescent patients, because we're showing in the research that this group is a high risk. So another major component of my job is teaching families about enzyme use. And it's a vital part of nutritional management. Without enzymes, we will struggle to achieve what we set out to achieve. And with enzymes, even with the best enzymes in the world, and even using enzymes to their best capacity, we still malabsorb. So even giving the best enzymes, you're still going to lose some calories through malabsorption. And a lot has developed in enzymes over many years, including now coating for them that allows them to not be released in the stomach, but to make it down to the small intestine where they're needed to act appropriately. So enzymes are very good, but even when we use them in their best, they're still not perfect. So how should we take enzymes? We know enzymes need to be taken whenever there is food or drink that contains fat, protein or starch. If we don't take the enzymes, there's no enzyme, no lipase there to help the body digest it. So the calories are wasted calories. We want to take the enzymes before the meal so that they're ready in the part of the body where they're needed when the food gets there. When children are younger, when they're babies, we want to mix the enzymes with yogurt or jam or a puree to make a paste so the child takes them appropriately. We want the infant to then take it with milk to ensure there's none left around their mouth. And as the child gets older and learns to swallow the enzymes, they need to be swallowed whole. If they're crunched or crushed, then they become very much less effective. And how many enzymes to take? This is one of the biggest questions I get from our patients. More fat equals more enzymes. So if you have a high fat diet, you need to take more enzymes. That's what the Toronto study showed us 40 years ago. As a rough guide, the European Society recommends 10,000 units, so 1 Cre on 10,000, for each 4 grams of fat. And on average, that works out to be 10,000 units per kilogram. So if your child weighs 15 kilograms, they would need to take 15 of the 10,000 Cre on. If you weigh 60 kilograms, you will need to take 60 of the Cre on 10,000, as a rough guide. The enzymes don't always work efficiently, but there's often a reason for this. Sometimes if they're stored inappropriately, if they get too hot, they become less effective. If they're crushed in the mouth, they definitely become less effective. If you forget to take them or there's a delay, you take them too late. Or if it's too acidic in the small intestine, all of these things can make the enzymes work less effectively. But in my experience, The reason that enzymes are less efficient is simply that children and adults do not take enough of them. So I'll give you an example. No one has to put their hand up and answer, but you can think in your head. Would you know how many grams of fat were in a bagel? You can think in your head. So there's 2 grams of fat in a bagel. What about a plate of lamb? Think about it in your heads and think, well, how much fat would there be in that plate of lamb? Well, that's a high fat content, that's 18 grams of fat. A creme brulee, a little pudding that contains lots of fat. The estimation is around 27 grams of fat. So I don't know whether you're getting this right, but lots of our patients, lots of the people I work with, and me a lot of the time, we underestimate how much fat is in these foods. And if we underestimate the fat, we underestimate the enzymes. Last one, a curry. You can think about how many grams of fat would be in a curry. In this one is around 16 grams of fat. And all of these foods contain 10 grams of fat. The point I'm making is, we have to understand the nutritional composition of foods so we can teach our patients so they take the correct enzymes. Now the way we teach it quite often is we tell children to take a food that they like to eat, like pizza, to look at the nutrition information on the back. And in this case, it says half the pizza contains 24 grams of fat. So if something contains 24 grams of fat, they're going to eat half a pizza. They do the calculation. 24 grams of fat. 4 grams of fat needs 10,000 units. So 24 divided by 4 equals 6. So the child will require 60,000 units of lipase. So that's 3 on 10,000 if they're going to eat half the pizza. And it's important that our families understand how to do this calculation so they take the right amount. Now there are many signs of incorrect dosing. There may be poor weight gain, which we see chronically. But acutely, patients will get symptoms related to their stools. So they'll get large movements, they'll be very smelly, they might be oily, they might have distension. All of these are symptoms of not taking enough enzymes. Sometimes our children can be a little bit embarrassed about talking about this. I actually get sent emails sometimes with pictures of people's poo, which isn't very nice, but people want to share their experiences, and if they're getting symptoms, it means inappropriate dosing. We need to correct that. Now the other thing that's important is vitamin supplementation. And this is another example of how taking vitamins is a little thing, but it can have a long-term impact. A little difference, but a big impact. So vitamins, we need to ensure they're taken appropriately by association. So we need to ensure that children remember to take them, preferably at the same time every day. We need to check in their bloods that they're taking them. We need to make sure that actually they can have good levels of vitamins. If the levels are allowed to drop, this can result in poorer outcomes. Vitamins need to be taken with enzymes. If they're not taken with enzymes, they won't be absorbed, and then it's a waste. And the recommendations for daily supplementation is on the European website for different ages. So we need to be ensuring that we're checking that as a child gets older, we adjust their vitamin levels accordingly. So we ensure they get the correct vitamin level. Okay. So the fundamental nutritional management of this group of children, we need to regularly review their nutrition. The younger the child, the more frequently we should check their growth. But at least every 3 months we should check their growth velocity, check their growth pattern, their BMI, maybe look at mid-arm circumference. We need to emphasise every time we see patients that they need a high-fat diet. They need high calories, a high-fat diet, and they need to take their enzymes. I think it's very important that we continue to put the message across that these things are important. every 3 months. So there's no doubt in our minds, and no doubt in our patients' minds, that these things are important. Okay. So in the next section I wanted to talk about what we do if those things aren't working. What do we do if we think we're giving a high-fat diet, if we're giving enough enzymes, if we're giving sufficient calories but the growth is still poor? What do we do then? Well, one option that's been available for a while is oral supplements. Oral nutrition milkshakes, high-calorie milkshakes. Now, there's not a great deal of evidence in the literature about the efficacy of these. There's been one very good long-term study in children, which was this study, the Calico trial here. And in this study, they gave children who had a poor BMI either supplement drinks, milkshakes with lots of calories, or they gave them normal standard advice. And they followed them up over a year. What they found, the red group is the group that took supplements. And the blue group are the children that just got advice. So you can see the group that took supplements did have a better BMI. They did do better than the people that given advice. But statistically speaking, it didn't make a significant difference. So the summary of evidence that we have based on a systematic review is that in some studies they might work, but there's not significant evidence for us to recommend them in all patients. But the point I wanted to make to you is that I have some patients who love the supplements. They enjoy taking milkshakes and they like them. And if they do, then it works. If they don't like them, they don't take them, and of course they don't work. So the use of oral supplements is very individualized, which means long-term studies such as this may not be the most applicable resource to look at. We need to look at the individual. And we did a study looking at how commonly supplements were used across Europe. And you can see here it's somewhere between 20 to 40% of children in these countries use oral supplements. So it's not a huge number of children, 20 to 40%. So practically, using oral supplements, we need to consider them when there's been a plateau in weight. So if you're a child and you're not gaining weight over 6 months, we need to do something. If you're an adult and your BMI is less than 19 or you've had weight loss, we need to do something. And this is where we can consider oral supplements. We need a child to be part of the choosing of them. So we need to allow the child to be involved in deciding which ones they want to take. We suggest using oral supplements at the end of the day, so there's minimal impact on solids. We don't want these drinks to take away the child's appetite for eating. Another option is to use tube feeding, which is very rare, but it's worth talking about. Now, there is more evidence in the literature. This is one such study that showed you could improve nutritional status and improve lung function by using tube feeding. So a gastrostomy into the stomach or a nasogastric tube through the nostril. So the evidence is a lot more suggestive that this, although more aggressive, actually leads to good improvements in weight gain and lung function. But really tube feeding is the very extreme cases. It's commonly used pre-transplant, for example. And again, when we looked at statistics for tube feeding, you'll see it's very, very rare across most countries. Somewhere between 2 to 10% of CF children may be tube fed. So it's rare, but we have to consider it if nutrition is very severe. The next thing I want to talk about is meal times. Put your hands up if you're a parent in the room, a parent of lots there. So meal times are stressful for all parents. I think we underestimate just how stressful they are for our children with cystic fibrosis. Most of our families tell us they don't worry about lung function numbers every day of the week, but they worry about feeding and eating 3 times a day because they're faced with meals again and again. So I just wanted to show you another video. I asked the same set of parents, how do you feel, these are parents of children with cystic fibrosis, how do you feel about meal times? And this is what they said.
They're quite hard work, pretty stressful really, particularly when he was younger and I was very conscious of trying to get him busy and ensure that he was having good quality food. It's getting a little bit better as he's getting older and he's got a good appetite now, but on the whole, yeah, fairly stressful to really think about unplanned meals.
Meal times can be very stressful because it is really important to make sure that you're getting the proper nutrition into your child. Luckily for us, we have a fantastic dietitian who supports us all the way and gives us various aids to help in this.
They can be really stressful because I know how important it is that he eats his meal, and I think he picks up on that, and it can be a nightmare to be honest.
At the moment, it's absolutely fine. My child is 2 and he's eating really well, but in the back of my mind, I'm a bit worried about the future because I think it could take a bit longer to feed him and he might get picky, and then he's got to go to school and how that's going to work out at school. Yeah, I'm a bit anxious about that.
So I don't know how similar that is to your experiences. Really, when I asked all of the parents, they all used the same word, that they found mealtimes stressful, or they found them a nightmare, or they found them very, very difficult. And I think we mustn't underestimate that this is the case. Some very interesting studies in America have filmed mealtimes of children with cystic fibrosis and found some very interesting things. Firstly, children with cystic fibrosis spend more time at the table, on average about 8 minutes extra. And on top of that, when they filmed the meals, they showed that actually the longer the meal time went on for, the less the child ate. And the longer the meal time went on for, the more the child refused, the more barriers they put up. And this is seen in CF children and in non-CF children, but it's seen to a higher degree in CF children. So what we know is in the second half of meals, it becomes more stressful, the children eat less food, they refuse more, they get down from the table more, and they become more non-compliant. So meal times get more stressful as they go on. And it's the same for the parents. When they filmed the parents, in the second half of the meal, the parents gave them more encouragement. They tried pushing more food into the child, but it was less successful. So meal times can be very, very stressful for the child and for the parent. What can we do about it? Well, the simple practical things that we can try. Limiting the time of a meal is quite crucial. So we would say for any child, the longer the meal goes on for, the more stressful. For a child with cystic fibrosis, the recommendation is around 25 minutes. If meal times are lasting longer than that, I would suggest that the child's not enjoying them, they're probably not eating very much, and it's making the situation more stressful. We want to avoid that. We need to help parents how to quantify calories by teaching families, and by families learning about the calories in foods. Sometimes they can be happy. They know their child has eaten enough because they know the calorie content of the food. We want to give children rewards for positive eating, like sticker charts. We want to avoid negative phrasing. So we shouldn't say to a child, if you don't eat that, you can't have this. We should say, if you do eat this, you can do this. Simple things that make a big difference. And we need to anticipate that there will be difficult times for eating, and they will be during toddler years and during adolescence. So in my last few slides, I just wanted to briefly touch on CFRD, just to say that all patients over the age of 10, according to the WHO, should be screened for CFRD. The later we pick up CFRD, the more likely we are to have more significant complications. Also, the later we pick it up, the more impact it has on nutrition. So picking it up early is very important. We know that CFRD is a very distinct type of diabetes. It's not the same as type 1 or type 2. Most notably, it occurs at the ages of 22 to 24, compared to type 2, which is for the older adult, and type 1 for the child. But the nutritional management of CFRD doesn't change our fundamental treatment for cystic fibrosis. We still give a high-calorie diet. We don't restrict carbohydrates. We still give them high-fat diet with lots of variety of foods. We perhaps teach them not to drink Coke, but otherwise we teach them to continue with a good calorie intake. Okay, so my last video, I asked the same group of parents, how important do you see nutrition? Bear in mind, I see these patients every 3 months. I said, how important do you see nutrition?
Well, I think it's really important, but there's so many things to think about, like his physio, like remember to take the enzymes at the right time, the right amount. So sometimes it gets neglected, but I do think it's really important.
It's really important. It's really important that he gets in the calories, that he's growing normally, looking, similar to his brother, and that he develops normally, really. So, but yeah, I do know it's important, and we work hard to make sure he eats properly.
Nutrition is a really important part of cystic fibrosis, particularly for my son, who's inevitably ended up being tube fed. I do notice a big difference when he's not eating. His energy levels drop, and he just becomes more susceptible to things. So, very big, very important factor.
I think nutrition is really important for a family in general with young children, but also for Finton, and we're very conscious that we feed him a good varied diet, but also it's high enough in calories for him, because we want him to grow and develop normally.
So the important message there, nutrition is one aspect of cystic fibrosis. It's a vital aspect. But we have to appreciate there are many different things that CF families have to consider. Nutrition isn't the only one, but it is still a vital part of their management. As I mentioned at the beginning, I like my job so much because I see growth and development, and I see charts like this for children who aren't growing, and I see improvements on charts that show nutrition is helping them. But I also get to see the child themselves, and I get to see children that go from this to this in relatively short spaces of time because of nutritional treatment, because of nutritional intervention. So in summary, we need to regularly review the nutrition of our cystic fibrosis patients. We need to target early nutrition. From the moment the child is diagnosed, we should be chasing good nutrition. Through adolescence and through adulthood, we're looking for the 50th centile for BMI. We want to provide them with a high-calorie, high-fat diet. If these things don't work, there are other options, like supplements and tube feeding. We need to appreciate that meal times are very stressful, and food is a very emotional thing for any families, but in particular for those with CF. So my last message to you is we should care about the nutrition of our group of patients. If you're a patient, you should care about your nutrition. If you're a doctor, you should care about your patient's nutrition. And if you're a parent, you should care about your child's nutrition. And the reason we should care is because it makes a difference. If we improve nutrition, we can improve lung function and a whole host of other aspects that will make things better. So we just need to share that message with everyone. Thank you.
Thank you for that very interesting presentation. We don't have that much time because you talk far too long.
Sorry.
But let's say just one question. If someone had one question, we could address that. Anybody? No? Okay, well maybe in a coffee break, you know what a nutrition man looks like, so you can ask your questions. You made me remind of some, I'm a CF parent myself, and I've been struggling in that area, and I remember this specific episode that my young son at one point totally didn't want to have any food anymore because I was annoying him with his little extra here and a snack there and a little cream in this and a little bit extra milk. So he was really, you know, fed up with it and he didn't want to eat. He was really stubborn. And then one particular night we were sitting in the living room and I heard this noise in the kitchen. It was this. This kid got so hungry, he started eating dog biscuits. Yeah, the laugh comes a little bit later because of translation, of course. So we know this is a psychological thing too, and it's very important that we address that.